Hello everyone, this is Shad Reyes and this is day 3 from TCT. There is a lot to cover today. I'm doing a wrap up for day 3, a lot of structural and physiology. So with that, let's move on. Forecast is a fractional flow reserve derived from computed tomography, coronary angiography in the assessment and management of stable chest. FFRCT has been validated before to evaluate anatomical as well as physiological information. However, in terms of evaluation and randomization of this technology, never been done before. They had a couple of things. Number one, cost effectiveness, and number two, if there's any adverse event in terms of management of these patients. As you see there, this is a number of patients, 1,400 patients randomized for 700 in each arm almost. You see the demographics are very similar. Again, all the test group had CTA, and the reference group had some of them are CTA, but they were referred eventually for coronary angiography. There was a 22% fewer patient had invasive coronary angiography in the test versus referred group. This is because the CT-FFR did not indicate any significance, and therefore the patient were not referred. So this is almost 1 in 5 patients were excluded going to invasive test based on this CTA. However, when they looked at the total cardiac cost, there was no difference between invasive and non-invasive or CT-FFR between the two groups. So that in terms of cost on the health system, there is no difference. Similarly, in terms of secondary clinical endpoint, MACE or clinical event, they were slightly higher in the invasive group, but this difference was not statistically significant. Therefore, the author concluded did not significantly reduce costs in the NHS system. Again, this is a British study, and is associated with a significantly lower rate of invasive angiography, but it's not has any clinical significance on these patients. So moving along to the target FFR, this is a physiology-guided optimization of PCI, a randomized controlled trial. Again, this is a very important study. As you know, there is a lot of patients who are underwent FFR, and systematic review of 7,000 patient found to have post PCI FFR more than 0.90. And have a lower adverse event. However, there is a 21 to 100% patient range, leaving 20% patient who have an FFR less than 0.9. Similarly, there is a 1 to 36% patient were left a cath lab with an FFR less than or equal to 0.8. And these patients, one third or more has reported angina after PCI, meaning whatever we did to these patients for FFR significant lesion, they still have angina post FFR. So what they did here is a PIOS group, meaning they randomized patients to post PCI coronary physiology, and if the FFR is more than 0.9, then the goal achieved. If it is less than 0.9, then they will do a pullback and evaluate the FFR if it is significant or not. If it is more than 0.9 after optimization, therefore they achieve the goal. If it is less than 0.9, then they have to do some sort of optimization. 39% of the patient has an FFR of 0.1 to 0.89, so it's above the threshold to fixing, but still low. But patient who has less than 0.8, please pay attention to that, it's 29%. 29% patient leave the cath lab or post PCI still has an FFR that is still flow limiting. And these are the breakdown also outcome patient randomized to who are received further optimization. As you see here, 40% of this cohort received the intervention. So result on primary outcome, there was a 10% difference between both group control and PIOS in terms of TVR, MACE, angina, but the P barely reached statistical significance, but there was a 10% difference between these two groups, meaning optimization helps. And the same thing, proportion of patients with final FFR less than 0.8, as I mentioned earlier, it was 30%, and now it is 18%. So we are decreasing the number of physiologically significant FFR because we optimize this therapy. In terms of cardiac death, TVR, or myocardial infarction, there was no difference between the both groups. However, there was, obviously, you are spending more time in the lab. There is the fluoroscopy time is more, radiation is more, adenosine is more, and procedure time is more. However, dissection, side branch occlusion, no reflow hematoma, all did not differ between the both groups. When they did follow up in terms of angina, indeed there was some improvement in the baseline compared to control, but this based on the survey, but this was not statistically significant. So in summary, geographically guided PCI, 32% of patients had FFR more than 0.9. 29% of patients had FFR less than 0.8, which is, this is what I think we have to spend more time on in practice and after we do angioplasty. And then based on the FFR pullback assessment and a substrate of further optimization, as I said, 46% of patients randomized to BIOS. Staying in physiology, this is a defined flow hypothesis. Abnormal FFR less than 0.8 but intact CFR, coronary flow reserve, more than or equal to 2, will show non-inferior outcome versus both normal 0.8 and 2.0 when treated medically. So again, this is the breakdown of the study. If this is less than 0.8, then it will look at the CFR. If it's more than 2, then it's will be differ PCI. If it is less than 2, then you have to perform PCI because you have two parameters that's showing that. Comparing the 4 groups together, and there was no difference in terms of primary endpoint, 2 years follow-up of MACE, death, MI, PCI, CABG between the FFR negative, CFR negative event is our 5.8, and the FFR positive, CFR negative, 10.8%. And so the primary conclusion, natural history of FFR positive, CFR positive, meaning normal, is not non-inferior. This is, imagine, this is two negatives, not non-inferior to lesion with FFR more than 8 and CFR more than or equal to 2. Another important study, I don't do CFR in my practice, I'm not sure how many they do it there, but something to keep in mind as well. Now let's move to the structural space. This is a very important study. I think it's one of the highlight of the structural coming from the European. In this study, this is they compare 2x2 provisional valve, or the commercial valve that we have, self-expanding and balloon expanding sapien and core valve in these two. But also they have another arm for local versus general anesthesia. So again, this is, you see a core valve, top of the line, Evolut R and Edward S3, and local anesthesia and general anesthesia. Primary outcome is 30-day composite death, stroke, pacemaker, and secondary is for anesthesia outcome as well. As you see here, the difference between the two groups is not significant. The 30-day primary endpoint was slightly lower in the sapien group, 25.9 versus 28.4, p-value 0.04. Now we are at 1 year at this point. Permanent pacemaker is the same, 54 compared to 44, similar to stroke. Was a little bit similar to however, the stroke, was lower in the Evolut R compared to sapien 3 with a p-value of 0.002. In terms of the, again, 1 year, this is another graph. As you see there was at 12 months, no difference in all-cause mortality, but the stroke was a little bit higher in the balloon expandable valve. Again, balloon expandable has a little bit higher strokes. And when they looked at the mean and the aortic valve gradient, it was also lower in the self-expandable valve. So more strokes in the balloon expandable and higher means after intervention in the balloon expandable valves. Anesthesia strategy, this is local versus general anesthesia. There is no difference, meaning non-inferiority. And all-cause anesthesia strategy in terms of mortality and stroke was also not significant, meaning local anesthesia work as good as general anesthesia as well. Again, the conclusion was similar rate of composite endpoint in both valves, higher stroke in the balloon expandable, similar time-related safety according to the VARC2 criteria, and lower aortic gradient in the self-expanding valve. Again, another cerebral embolic protection study. The primary endpoint, they would like to see if there is any clinically significant difference in the stroke rate between these two groups. In terms of utilization, as you see, there was an increase in the last quarter of 2019. It's still at 28% in the center, but the proportion receiving that therapy is 13%. There was more dialysis patients in the no protection, and bicuspid was also higher in the protection. I'm assuming that's difference because maybe this patient is younger, because the calcium is more calcified. Therefore, they're aware maybe there's a concern for embolization. However, in terms of the endpoint, in hospital stroke, there was 1.39 in the protected cohort and 1.5 in the non-protected, meaning there's the p-value of 0.41, no difference. And this is similar to what we saw yesterday on the REFLECT 2 trial that showed no difference as well using a TriGuard. They did some propensity match analyses after controlling for adjusted based on overlap propensity weights. There was slight improvement or better protection and lower strokes in the EPD cohort compared to non-PED, was statistically significant. So again, this is not a randomized trial. This is an observational study, but it's still showing that there's no benefit in hospital stroke in these patients. But there is a signal, especially in patients who are high risk, more calcification, and there was a call for more trials. Staying in the structural space, this is a MITRABRIDGE. This is a very interesting study done in Europe as well. This is bridging a patient who has advanced heart failure, are on the list or listed or worked up for transplant, and if their ADP and diameter is big, therefore, and they have a moderate to severe mitral regurgitation, does the mitral clip helps? Again, this is a 3 cohort of patient who are already listed in list group or pure bridge, or patient who are bridge to decision, or a patient who are bridge to candidacy. And this is, they looked at all-cause mortality or urgent heart transplant or first rehospitalization for heart failure. This is the breakdown. Majority of them were bridged to decision. Again, there was a reduction in the primary endpoint, which is all-cause death, as well as need for LVAD heart transplant or first rehospitalization in the patient who received the mitral clip. And then in terms of secondary endpoint, also there was difference and all favoring all the groups and list, bridge, as well as with decision. And they concluded that maybe 2/3 of the patients remain free of developing composite adverse event at 1 year, and 15.5 became eligible for heart transplant because they got better and they are maybe in better shape to receive the transplant. And they are, as you saw in the demographic, they are a little bit younger as well. Moving along to the next one, Global Expand, Core Lab Adjudicated Contemporary Clinical Outcome. This is for the new iteration of MitraClip, NTR and XTR. As you know, they have bigger, longer arm, but also a better gripping system. They looked into all the cohort who received this device, and then especially the new technology compared to the old one. Again, you see a majority of the patients received the new technology, and there was a significant improvement in heart failure hospitalization in this cohort of patients, whether compared to the one at 1 year that did not receive pre-clip, a reduction almost by 52%. And they concluded in this study that the patients who received this new technology are achieving better mitral regurgitation, trace to none, and also they have a better outcome compared. With that, I will conclude all the trials from day 3. You can access all of this on TCT MD. You have access to the PDF as well as the PowerPoint. Please feel free to use it. Thanks again to the TCT team for the help. With that, thank you so much for watching. This is Shadi Reyes from Heart Trending.